Thank you, Lynn, for the lovely introduction. And Andrew, thank you both for inviting me to speak with your audience today. It's a pleasure to be here. I'm thrilled and honored to be invited to speak as part of your speaker series. For those of you in the audience, as you can see from the slide, we're going to talk a little bit about personhood and when we're communicating with people who are living with dementia. As part of any talk that researchers have to do, I have to disclose that I don't have any financial arrangements or interests associated with Brock University. I don't have any financial or other affiliations with pharmaceutical or medical device folks. And I promise that my recommendations are going to come from the scientific literature, not informed by opinion or beliefs. I also have to indicate, as Lynn's pointed out, the grants that I hold, some of them include those from the Tri-Councils of SSHRC, as well as the Ontario Brain Institute and the Ontario Neurodegenerative Research Initiative, as well as CIHR and others. A recent one that's just come in from NIH with my colleague, Angela Roberts, on super aging. So what do we want to do in the next series of 35, maybe 45 minutes or so is to talk a little bit about what person-centered communication is, and then link that to the concept of the syndrome of dementia and the communication and language and cognitive issues that happen for people who are living with dementia, and then go over some of the literature on person-centered communication, some of which is in the extant literature that my colleagues have published, but also a couple of studies of master's students of mine in my lab. I have quite a bit of information, so I hope to get through all of it today. You'll see the slides numbered in the bottom right-hand corner. They're off a little bit because of some other slides I've put in here, but we're going to try and move through so you can see how far along I'm getting in the presentation. As Andrew's pointed out, there'll be some opportunities for questions at the end. Unfortunately, I can't see the chat box, so if people are posting questions, I'll have to get either Lynn or Andrew to read them out to me towards the end. So setting the foundation or framework, what is communication? Because that's one of the themes in the presentation today. Communication really refers to the exchange of information between two entities, you and your mind, or you and someone else. And there's a dynamic role that happens between the speaker and the listener, or the reader or the writer, or the gesturer and the viewer. But really, we use communication to exchange this information, but just as, if sometimes more importantly, we use it as a mechanism to maintain and change relationships. And communication has multiple forms, including interactional ones, including transactional forms of communication. But really, as this picture illustrates, communication is the keystone in the arch of human relationships. There's nothing you can do with another person that doesn't involve communication. Communication has a variety of modalities, including from the expressive line, the speaking that I'm doing now, the typing that I did in my word processing, the nonverbal elements that allow us to express, but also from you as the listener and the viewer. You hopefully are understanding what I'm saying. If you have auditory comprehension, you see the material written on the slides. It's in the right font. It's large enough, and that you also are picking up on my nonverbal. At least it's hard to do that through Zoom or in this case Microsoft Teams. But you also have other modalities besides the auditory and the spoken and the written and the visual, and that includes smell, taste, touch. And those modalities are often used as alternate channels when some of the main channels aren't working. So that just sets the framework for what the broad concept of communication and the modalities. Let's move on to what we think of in our literature as the concept of person-centered care that's often shared by our colleagues in nursing, occupational therapy, medicine, psychology, among others. Essentially, person-centered care is taking into consideration person's values and preferences that guide all of our health care and support our realistic goals and life needs and desires. And achieving that requires the collaborative, informative decision-making that our client, those whom we serve, desire, whether it's a resident, a patient, a participant, et cetera. And that's the driving concept in most centers, certainly in Canada and socialized healthcare, that really we're making our care person-centered. So what then is this concept of person-centered communication? And really it's a philosophy that supports the principle of focusing in on our client, our partner's needs, their value, their respect as a person, and to promote an individualized approach to care within the context of what communication is. Within the context of the type of diagnostic condition we're talking about today, dementia, we think of person-centered dementia communication is using person-centered care within the context of the language elements that happen and get displayed by people with various types of dementia, as well as taking into consideration their cognitive, vision, hearing, language, and needs as well. So I've used the term dementia, and I want to make sure that we're all singing from the same song sheet, that is the same perspective. Dementia is a syndrome. It's a collection of various different types of diseases, and what I have on the slide here is really the research criteria that have been refined over the past several decades to refer to a condition in which people's cognitive skills change over time. It's not explained by delirium or major psychiatric disorder, and that there's some sort of history from the client or a knowledgeable informant, a significant other, a care provider, and there's some objective performance measures in the cognitive vein, either in mental status or neuropsychological testing, that shows that they have here an impaired ability to require or remember new information, essentially a memory problem. They have impaired reasoning or handling of complex tasks, which we refer to as executive function challenges. They may have visual spatial difficulties as well, that include seeing foreground from background, the door opening towards you or away from you. And the highlighted area in red is our interests in language and cognitive communication challenges. And then finally, some changes in personality or behavior. And you have to have 2 of these 5 areas impaired in terms of the most recent research criteria. The American Psychiatric Association developed and published in 2013 a new set of criteria in their diagnostic and statistical manual that referred to dementia really as the major or minor neurocognitive disorder, but essentially it refers to the same syndrome of dementia, but they've added in a couple of different diagnostic criteria. And the last one I'll show you on the screen here is number 6, which is social cognition, which really refers to the ability to use your language and communication in a variety of social contexts that hadn't been captured before in previous definitions. There are many different types of dementia within the context of the syndrome of dementia. And you can see in the top left-hand screen that we have dementia, the Alzheimer's type, or DAT, or sometimes referred to as Alzheimer's dementia. And it has multiple different subtypes. There's the mixed dementia that includes Alzheimer's type dementia and vascular dementia, or cerebral vascular dementia. Further down on that left-hand side of the screen, you see frontal temporal lobe dementia or frontal temporal lobar degeneration, which includes a number of different types of dementia. And then on the top right-hand side of the screen, you have dementia associated with various motor neuron diseases, including Parkinson's disease, ALS, multiple sclerosis, etc. So there are many different types. And why do we even want to be concerned about this? Well, dementia is prevalent worldwide. It's been estimated we have over 50 million people worldwide who are suffering from dementia, about 10 million new cases per year, of which you can see the majority of them are happening in Asia and in Europe. And it's based on and stratified based on age, so that between 5 to 8 persons with dementia occur per 100 in the 60+ age group, and that the cost to look after people who are living with dementia and their care providers is astronomical, reaching the trillions of dollars worldwide. That may be the worldwide features, but what about Canada? We have over 500,000 people who are estimated to be suffering and living with dementia. Many of those cases are people who have Alzheimer's type dementia, and there's more women than men, close to being 2 to 1, and that it's stratified again based on age, so that those who are over the age of 85 or in the old group tend to have a very high prevalence of dementia. And of course, we estimate that in 9 years from now, we'll have close to 1 million cases in Canada. And the cost even in Canada is astronomical, currently estimated at 33 billion, both for direct and indirect costs. So if we link then the concept of communication, person-centered communication, and dementia, we have to think about this idea of these challenging or responsive or communication behaviors that are linked to these problem behaviors. And a model published by one of my colleagues, Maurice Savundanayagam, linked communication problems in a correlational way with some of these responsive behaviors, or sometimes referred to as problem behaviors, that led to communication challenges and then burden on the care providers. That included demand burden, which was actually trying to help the person physically, stress burden, which was actually the emotional component associated with trying to care for somebody who was displaying these responsive behaviors, and finally, objective burden, that is, the care provider was suffering from dementia, their physiological features changed, and they required medications, etc. So this particular model linked that the challenges that we often see in people who exhibit dementia and problem behaviors are linked with the communication problems. So many of our interventions then should be targeted at reducing these problem behaviors or responsive behaviors. And clearly there's this reasonably robust link between these communication problems and the problem behaviors that, for an intervention perspective, we can minimize the demand and burden on care providers by helping reduce these responsive behaviors by improving communication and minimizing these communication problems. Now, within that context, we have to place people who are living with dementia in the larger context of all older people, at which there is a huge number worldwide, and the number of older adults, either at the age of 60 or 65, whatever your old threshold, is rising substantially. And one of the models developed about how we communicate with older people was first developed in the early 80s. It's called the over-accommodation communication model, where older adults are encountered by others and people recognize their old age cues. And this led to various types of stereotyped expectations or behaviors of their performance, in which we then changed or modified our speech behavior. And it was referred to as elder speak or secondary baby talk. And that type of talk or demeaning talk to older adults lessened their self-esteem. It reduced their status. They began to act like children because we talked to them like children. And that eventually evolved into this model called the communication predicament of elderly people, published by my postdoc supervisor, Ellen Ryan at McMaster University. And the features of this elder speaker patronizing talk or secondary baby talk included features that were first described by Linda Corporeal at Rensselaer Polytechnical Institute in Utica, New York, back in the early 80s, included high pitch, exaggerated intonation, and use of nicknames, first names, or terms of endearment, honey, sweetie, dearie. And essentially the findings from Linda Corporeal's study was that this prevalent elder speak secondary baby talk was similar to preschool language speech production, and that it was used by staff who held negative attitudes or views about older adults. The features of this elder speak include, as I indicated, high pitch, slower speaking rate, closed-ended questions, presumptions of poor memory, and nonverbal behaviors that I'll describe shortly, as well as short directives, short utterances. That is, people were controlling the types of interactions they were having with these older adults, regardless of whether the person's needs were taken into consideration. So this concept of the communication predicament or over-accommodated communication was really the antithesis, the opposite of person-centered care. In the mid-90s, Ellen Ryan, I'm sorry, it's not really very clear on the screen all that well, described some of the verbal and non-verbal features of this elder speaker secondary baby talk. And interestingly enough, not only could people hear that the pitch was changed, the speaking rate was fast, and they were highly directive, and the grammar was simplified, and that you manipulated the topic, but you also heard and saw people with arms crossed, huffing and puffing, eye rolling, watching their watch, etc. So all of these features then conspired the individual with whom they were speaking, the older adult, to all of that negative consequence of that communication predicament model. Susan Kemper in the United States looked at the consequences of these features of elder speak and what people held in their views about older adults, and that there were these negative stereotypes and poor self-perceptions of the staff as well as older adults who received this. And they also identified what was actually some features of the elder speak that might have been helpful. That is, repetitions, rephrasing, and simple sentences and grammar that often appear as elements of elder speak, but can be helpful for certain types. And so not all elements of elder speak are bad, depending on the person's profile of language and cognitive skills, but there are, as a collective, negative consequences for using these types of features indiscriminately. Of course, in life, there is the yin and the yang. And so we developed, Ellen and I, along with some colleagues, the communication enhancement model that built on the same principles of the communication predicament model, where you encounter an older adult, you recognize some old age cues, white hair, stooped posture, using a cane, names like Thelma, Herbert, Wilma, and dates of birth, 1932, 1947, as indicators of older adults. But what you do is you modify your communication on an individual basis, and you enhance that communication, as in the context of person-centered communication care, and that optimizes the effectiveness of your interaction and also optimizes the well-being of yourself as the care provider, and as well as the person with whom you're interacting, the older adult, the resident person. And so our model has been tested in a number of different ways. As a matter of fact, this is a most recent depiction of an expanded version of the communication enhancement model that just got published in 2022 by our colleagues at University of Manitoba, and I won't go through it in detail. But on the right-hand side of this slide, where it says the supportive person-centered enhancement components are the added elements to the basic thrust of our model. So we're very pleased to see that individuals were building off our model. So I've talked about I've talked about centered care, but let's delve a little bit more into the literature on what personhood and self is. And Ellen Ryan's talked a little bit about it and published it, that really this self and personhood for people with dementia that sometimes is viewed by others in a stigmatized myth way, that they lose who they are as self. But really, we think of personhood and self as this standing or status that one has or one bestows on oneself. And really, adopting this concept that self and personhood are retained in individuals with dementia sometimes is the antithesis of, again, the opposite of what the biomedical model says. Well, she's lost her mind, he's not himself again because he has Alzheimer's type dementia, etc. Couldn't be further from the truth. And so part of our role in research in this area is to ensure that self and personhood remains at the forefront of some of our work. And colleagues like Stephen Sabata in the United States have identified features that show this interdependence and interconnectedness of people living with dementia, and then to develop communication strategies or patterns that are person-centered that reinforce these features of self or personhood. So when people with dementia begin to use words like I, me, my, or mine, that's a reflection that they still have a concept of themselves. They describe features of themselves, their beliefs, their characteristics, the talents that they have. And the third area that Sabat wrote about is that these people describe their public persona, that I was the treasurer of my women's group, or that I was a hockey coach, or that I was a teacher and instructor, or that I was a great volunteer for my local community. So these three features, well-documented literature used by people with dementia, show that they still retain this notion of self and personhood. So as researchers, we want to capitalize on that. The late Tom Kitwood from the UK, and I understand there may be some colleagues joining us today from the UK, talked about a whole set of features of people who are living with dementia about their personhood. And there are 4 of these characteristics that we've adopted in our literature that includes recognizing people who have a particular feature, their unique characteristics. You negotiate with them, that you offer them the opportunities to select particular preferences or choices. You validate who they are as a person. You work in collaboration with them, and finally, you facilitate that interaction through a variety of linguistic and nonverbal features that I'm about to show you and go through in the literature. And one of the concepts of using Kitwood's positive personhood reaffirming features is in the concept of reminiscence therapy. And some of you may be familiar with reminiscence therapy as this life review component in which you work through in a systematic way all of those elements of a person's autobiographical episodic memory, that is, event-based memory. Those particular features of your life that are most memorable, when you were on a last memorable vacation, when you got married, when your children were born, those particular epochs mark your autobiographical memory. And using reminiscence therapy through narrative discourse, you can permit and enhance and provide ramps for the person who's living with dementia to call upon those person-centered relevant features that are well and much better preserved in their autobiographical episodic memory. And so reminiscence therapy incorporates the use of multiple sensory personally relevant stimuli to allow the person who's living with dementia to retrieve and recall that information through recognition of various stimuli. and that you choose particular topics that are historical themes or calendar based, that mark certain holidays or particular memorable events in the person's life that allow them to then reflect and reveal who they are more as a person with dementia, because they can't do that without some assistance or support. So what I want to go through in the next series of slides is a study that one of my former master's students, Kelsey Dines, did to use an iPad to enhance person-centered communication for people living with dementia and their family caregivers. Her study really tackled the issue of person-centered care within the context of electronics, but also building off the work from Michel Bourgeois in the United States, who had these memory notebooks or conversation notebooks. So Kelsey's study really looked at, could we use in a collaborative way these electronic features of an iPad with a particular piece of software that I'm going to show you to enhance the person-centered communication of the care providers, and see if that actually enhanced that interaction and well-being of both the person living with dementia as well as their care provider. So Kelsey undertook a study in which 7 persons who were diagnosed with mild to moderate Alzheimer's type dementia with family care providers, 6 who were spouses and 1 was an adult child. And we use a particular piece of software called Pictello. You can download it from the Apple store. Right? Yeah, software store. I don't have any shares in the company, so I'm not trying to shill it, but I think it's around $30 or so. And what you do is you take pictures of, or excuse me, take snapshots and upload these pictures from the photo album that the person may have. And in our particular case, we uploaded 40 photos that were pre-selected by the person living with dementia and their family caregivers. And part of the protocol is that, as you can see in the illustration, you take a picture of the family dogs, for example, and then you type in, along with the person living with dementia and the family caregiver, a SAD sentence, simple, active, declarative sentence, a single subject, of active verb, and a direct object in the present tense. And then you get either the family care provider or the person living with dementia to actually read that sentence out loud, so that when the family care provider or the person living with dementia touch that screen, the voice comes up, either the person with dementia or the care provider, that says, in this particular case, the dogs play at the park. And so you have Miller, the dog, and the other dog in that picture, and they hear that and they see that, and that's to stimulate interactions and communication. So this particular study involved a 6-week trial in which the first week we did all of the baseline data collection for background information and getting people familiar with their knowledge of how to use an iPad and their knowledge of person-centered communication. We then did a baseline interaction of 20 family photos 2 to 3 times a week with the family care provider. That the researcher was not there. We trained them how to do that, and they did that 2 to 3 times for the first week, gathering an audio recordings of their person-centered communication, transcribed it. And then in week 3, we trained them specifically about what these features were of person-centered communication, and using the Kitwood facilitation, negotiation, validation, and recognition. And in weeks 3 to 6, they did that 5 days a week, in which they randomly recorded their sessions twice a week during that period of time. And at the end of week 6, we administered the second questionnaires for them. And as I indicated, we transcribed and segmented all the audio recordings, and then coded for these features of recognition, facilitation, negotiation, and validation. And so what did we see in the study? Well, as you can see, at baseline, they were pretty low, at about 0.4 or 40% of the time. The person living with dementia used these person-centered strategies, and the family caregiver was about 52%. And as you can see, over the a period of weeks 1, weeks 2, weeks 3, and then they plateaued at week 4, they reached a significant increase in their use of person-centered strategies of negotiation, validation, etc. So we thought that the use of this iPad and the interactive patterns using photos from their own lives that tapped into episodic autobiographical memory really revealed this person-centered capability of the care provider as well as the person living with dementia. So they move from a little less than 40% to over 45% of their utterances involving person-centered communication. So that meant that certainly the person living with dementia could actually use and learn these particular features. And so the future implications for our study, which are ongoing in other students in my lab, are that we're going to rely on these electronics, and that there may be some long-term effects of person-centered communication, but we don't know that yet. And we know that in our particular study that caregiver burden and depression and quality of life changed only marginally, but given that we only had a 6-week period of time, so we need to see the effects over a long period of time. And that we also need to know that, will this happen with other types of dementia, persons living with frontotemporal lobe dementia, including the primary progressive aphasias, or those with Parkinson's disease? We don't know that. So we want to, in future studies, see how well the Pictello program can be used for other types of individuals, particularly for those individuals who might show frontotemporal dementia, the behavioral frontal variants, in which there are lots of these catastrophic emotional reactions that there's plenty of evidence now that a virtual reality may calm these individuals down, but would, reflecting on person-related pictures from their family of photo albums, help reduce some of these responsive negative behaviors. And so we're hoping that we'd be able to test some of those in future studies. So that's just one example of an intervention study to try and get people to enhance their performances on using person-centered communication. So one of my colleagues, Marisa van der Nijgam, and her master's level student, Kelsey Moore-Nielsen, looked at what were these language-based strategies that support person-centered communication. And they were targeting a study that collected data from staff resident audio recorded interactions in long-term care home during daily routine activities. And they recorded these conversations over a 12-week period of time, and ended up with 46 conversations over this a 12-week period at 4 different, 4 different time points that they gathered their data with different dyads. And what did they looked for? They looked for the person-centered categories that we've all been looking at: recognition, negotiation, facilitation, and validation. And they also looked at specific language strategies that might actually link to these person-centered care categories. And there were 21 different features of language, including rephrasing, repeating, types of different questions, using greetings or affirmations or terms of politeness that might otherwise mark these person-centered categories. And what they wanted to do also was to see whether these person-centered utterances and their language-based utterances overlapped. And so you can see that in this particular diagram, the overlapping in the Venn diagram, that in these interactions, they only had 586 of their utterances that could be classified in those 4 Kitwood categories only. And then they had over 1,100 that were only language-based strategies only. But then they looked at whether the person-centered utterances overlapped with those language structures. And clearly at 1,692, the majority of those person-centered utterances that overlap with the predetermined evidence-informed literature on language strategies that were person-centered were substantial. And when they broke down into each of these different categories of recognition and negotiation, you can see, for example, in the recognition PCC category, that mostly it was greetings, affirmations, and rephrasing that constituted the person-centered type of language strategies that overlap with recognition. In negotiation, of course, not unexpected, 70% of those linguistic utterances that were negotiation PCC were in the form of yes/no questions. So van der Nijgam and Moore-Nielsen also categorized the types of language structures in facilitation, and found that yes/no questions, affirmations, and open-ended questions were really the bulk of those categories of language structures that overlap with facilitation. And then, of course, in the final category of validation, it was affirmations. I validate who you are. I affirm who you are. And so their particular work was groundbreaking in that they began to then match these psycholinguistic features with the categories of person-centered communication. Interestingly enough, our colleagues at the University of Manitoba began to look at ways in which we could provide feedback to people about educating and training them on person-centered features of communication. And in their publication back in 2020, they looked at video feedback. If we showed people the features of negotiation, validation, and particular language structures. Would that help them in many ways? And so their publication actually started them off on a larger study that really was incorporating the video feedback and an education and training program that is connecting people through conversations using video feedback to enhance the communication patterns of staff in long-term care facilities. And so O'Rourke and colleagues looked at matching of 11 healthcare aides with 10 people who are living with dementia, and it was all types of them, mostly in the mild to moderate, who were in long-term care. They audio-visually recorded through a Microsoft Surface tablet the sessions of interactions of usual care, building off the work that Marie and Kelsey Moore-Nielsen had done. And they did an intervention as part of this study, in which they provided a 3-hour educational session on the theoretical and empirical evidence of what person-centered care was and person-centered communication for people who are living with dementia. They also then incorporated from their previous study a 35 to 40 minute or 30 to 45 minute video feedback session 2 to 3 weeks post their education session to identify person-centered communication. Again, a very busy slide. I apologize for that, but I've highlighted in red those types of changes, both pre and post intervention from their audiovisual recordings. And you can see that the number of care aid statements that were coded as person-centered went from 88.27 to 116.5, a substantial significant increase. And the same number of reciprocity statements went up. That I'm reciprocal with you, I'm in touch with you, those went up significantly, as did the number of continuity statements. That is, I'm continuing on what you're saying, I'm not being abrupt and controlling the conversation. Those went up substantially as well. The number of uncategorized statements dropped. That is, those that couldn't otherwise be viewed as PCC. And overall, you can see the overall person-centered dementia communication statements went up substantially from close to 115 to 151 on average. And then, of course, these self-report measures by the care providers regarding their comfort scale improved substantially, as did their relationship closeness, as did their self-reflection of work. And so the O'Rourke study showed that, yes, we can educate and train folks and have the empirical evidence audiovisual to show that they're actually changing their linguistic structures and keeping more of the person-centered as paramount within their vernacular. I'm going to switch now to another series of studies, these undertaken by a master's student. As a matter of fact, Emma Bender, a student in Marie Souverin-Igam's lab and on whose committee I sat, is just finished successfully defending her master's thesis, the data I'm showing today, just now. You may have heard a couple of dings on my computer here that indicates that she's actually just completed her thesis and successful. So I'm giving you hot off the presses data from Emma's master's thesis. Her first study was a scoping review in which she began to look at the supportive strategies for nonverbal communication of persons living with dementia. And so she did this scoping review that identified 16 studies through a substantial evaluation of the literature to look at what were the nonverbal features that people thought were supportive of people who are living with dementia. And again, not a very large slide. I tried to enlarge as best I could, but what Emma found from the scoping reviews that eye contact, gestures, facial expression, touch, close proximity, and frontal orientation were identified in these studies in her scoping review as being supportive of nonverbal communication for people living with dementia. And as you can see in the far right-hand column under quantity, the majority of studies and researchers investigated nonverbal showed that when you look into each other's eyes, you make that eye contact. 11 out of the 16 studies identified that as an important element, as did using arm, hand, and head movements, including illustrations, as well as using positive facial expressions or mirroring expressions. So these were some of the features that were found in her scoping review. Moreover, what she also found as part of her scoping review was that the successful task completion, reducing responsive behavior, the increased expression and engagement, improving comprehension, and fewer communication breakdowns were outcomes of using these particular nonverbal features. And so in the middle column, you can see what was extracted from each of these studies that people described: promoting cooperation, recognition of people or actions or themselves, elicited effective or verbal responses for persons living with dementia, increased their attention. And then you can see in the far column the study. So I thought Emma's study was appropriate, and that was the first part of her master's thesis, to begin to look at how nonverbals contribute, because we've had studies that show the language stuff, but what about the nonverbals? So Emma went on to conduct a second part of her master's thesis that looked at the relationship between the nonverbals and how these person-centered communication overlap. And so she looked at interactions between audio and video recorded interactions between long-term care staff and people living with dementia. And from a previous database that Marie Savunanagam had in her lab, Emma randomly selected 40 of those interactions and then coded them for these 10 nonverbal communication strategies that she had developed. And what she found was that there really was this overlap between the recognition, negotiation, validation, facilitation, and these nonverbal communication strategies, much like what Marie and Kelsey had found previously, that 68% of the person-centered communication units had some nonverbal components attached to them. And so what she ended up seeing was that gaze and gaze plus touch together really were used across almost all the person-centered communication units in the interactions. That the facilitation and negotiation ones included gestures with an object, and then recognition and validation included positive facial expressions, and that recognition included gaze and validation included touch. So really, we were beginning to see very systematic evaluations with empirical data collected from large samples that are beginning to unveil the linguistic as well as the nonverbal features that support person-centered communication. I'd like to turn our attention now towards a study that my colleague Marie Savunanagam is leading us on. It's called Be Epic, and it's a person-centered communication program for training PSWs in long-term care facilities. So I'm going to give you a quick summary of the Be Epic program. And EPIC is really an acronym that stands for Environment, Person-Centered Communication, I Matter, and Clients' Abilities and Preferences. And Marie and some colleagues of ours have published the first part of the study of Be Epic that really incorporates an education and training module that started out using simulated patients to interact and train with staff to show how you should be communicating appropriately. And the Be Epic has a series of modules that focus in on person-centered communication and delirium, which is a common condition in long-term care facilities, as well as having a focus group session in which you can debrief and feedback. And essentially, it's a face-to-face rather than the video type of approach that O'Rourke and colleagues had used from the University of Manitoba. And so from the first part of Marie's early studies on Be Epic, she found that the training improved in the blue line, the proportions of person-centered communication utterances that staff were using versus a control group in which there was no training. You can see we moved from about 60% all the way up to almost 70% using person-centered communication in people's utterances. And the other interesting phenomena that Marie is identified is this notion of missed opportunities, that there are opportunities when long-term care staff or care providers can actually use person-centered communication to negotiate or validate and recognize people's performances. And she also found that those instances in which there were missed opportunities declined over time. That is, the training and education around person-centered communication actually improved their use, which means that I'm missing fewer of the chances of using it. So I thought her study was very creative and innovative. The next step for Marie's study is what we're working on with Employment Skills Canada. It's a large study in which instead of using simulated persons living with dementia, Marie has developed virtual reality. And so staff will be trained on how to interact with a person portrayed in a virtual reality, an avatar. and we're developing two of these avatars, an older gentleman and an older woman, one of whom is from an ethnic minority. And we're training through artificial intelligence and machine learning using the conversation databases that I've had in my research and those from Marie's, in which we've captured conversations with family members as well as long-term care staff to drive interactions between the staff who's wearing the headset and interacting with the avatar. James and Nala are the two avatars. And it's just phenomenally creative to train and educate staff in an interactive way to have them improve their person-centered communication and to restore the dignity of people living with dementia. So you'll get more of this. It's the VR Be Epic that's coming out in several years. We're just in developing the interactive facilitator sessions now. It's phenomenal. I would be remiss if I didn't talk to you a little bit about some other education and training programs by some of my colleagues in the field, including Jeff Small at the University of British Columbia, who developed the TRACE program. Again, it's a very systematic way of educating family care providers as well as long-term care facility staff about how to use compensatory strategies. And on this first slide, it's mostly about all those language features that are helpful in interacting with people living with dementia. But as part of the TRACE program, besides the compensatory strategies, Jeff and Joanne Perry, his colleague, also talk about these connecting strategies that link really to some of the features of Kitwood's principles of negotiation, validation, recognition, and facilitation. That includes connecting strategies where you encourage the support of comments for the individual to participate in conversation. And others talk about that as connecting strategies or sustaining strategies. Jeff and Joanne talk about issues around assisting the person, linking up the person, expanding, using positivism in their context of how to train and educate care providers in working with people living with dementia. There are many other approaches that have been used, not necessarily specifically within the field of person-centered communication, but have different context in which we optimize the communication for persons living with dementia using music or pets or massage therapy, gardening therapy, programs to train students interacting with older adults in exercise programs, Sharon Arkin's work in the United States, as well as Mary Jo Santo-Pietro and Jeff Smalls on using activities of daily living programming like breakfast clubs or routine patterns that actually capitalize on people's autobiographical memory and routine elements. So those are just some of the studies and elements of person-centered communication that I think would be relevant for you to give you the broader spectrum of the literature in which we operate as speech-language pathologists. I bring to your attention, I won't show you this particular video, but hopefully those after can access Dr. Susan Lane's whiteboard video that incorporates some of the strategies that Jeff Small has talked about and incorporates person-centered communication. It's a wonderful whiteboard animation of all those compensatory and connecting strategies that Jeff talks about. It's about 2.5 minutes. It's a wonderful video that really captures the essence of these person-centered communication language elements. But what I'd like to finish up though is showing you this video, and I hope it works. We played it earlier on. So let me just set this up a little bit. This is a video from the movie Iris, in which Judi Dench plays the very famous British novelist Iris Murdoch, who over the course of the film demonstrates her development of dementia. And I particularly like this film as a researcher in speech-language pathology because it captures the essence of the language declines that are common in people who are living with Alzheimer's type dementia. And I've got a particular snippet here. It's a little over 2 minutes. And again, I hope you can hear it. But I use this as I think a useful teaching tool that her husband, in this particular case, John Bailey is her husband, who also is a novelist, an English professor, identifies that it's really Iris's entire life as a novelist that really remains as a part of her, and herself and personhood are there. And in a poignant interaction towards the end of this clip between John Bailey and a psychologist, John points out that we really need to be in touch with those whom we're providing care for, our loved ones who are living with dementia, because we need to learn their language. And once we learn their language and how they tick in how we can actually bring out that self, that will make our care and their lives much better. So I'm going to play this. This is the last slide until we get to the last ones at the end, but I hope it works. So let me see if we can get this going here, and I hope you can hear it.
Not just sorry, but shall I read to you? Shall I? Occupied in observing Mr. Bingley's attentions to her sister, Elizabeth was far from suspecting that she was herself becoming an object of some interest in the eyes of his friend. Mr. Darcy had at first scarcely allowed her to be pretty.
I wrote.
Yes, my darling, clever cat. Books.
Books. I wrote.
You wrote novels. Wonderful novels.
I wrote.
Such things you wrote. Special things. Secret things. Do you know many secrets now, Iris? You have shown me a map of Iris's brain world, empty. You tell me that its hidden mysteries and all the unknown life in there has gone, has been wiped. How then can she say things of such a terrible lucidity? Which bit of the empty jungle does that come from?
We don't know.
No, you don't know. Don't hide, please. Is it not remotely possible that what Iris says is of some consequence, yes?
Yes, perhaps.
So perhaps we ought to learn her language before the lights go out, what?
The lights will go out.
Yes, of course they will. You all keep telling us that. I know that. She may even know that herself. Not just.
So that concludes my session, but I do like to end on that particular video segment, because really the character John Bailey captures the notion that we really need to get to know the language of the people living with dementia, and that just is a wonderful way of incorporating and encapsulating the concept of person-centered communication. So thanks.